Hello, everyone. This is Professor Flourish. I just want to go through acid-base balance with you all. Now, what I do personally for my acid base is I always like to start with the chemical. So we've got bicarb, hydrogen, and CO2. Bicarb is a base, hydrogen is an acid, and CO2 is an acid. The lung chemicals are your CO2. So whenever you're thinking of CO2, you're thinking of a respiratory problem. With kidney chemicals, we're thinking of bicarb and hydrogen. And a lot of time with hydrogen, we're thinking of stomach acid, and bicarb is a base. So kind of keep these in mind as we continue on in this lecture. So pH is what we usually start with, and with pH, it's that 7.35 to 7.45. What I want to make you aware of is that these are ranges, so depending on the facility you work at, the ranges may be slightly different, but you want it generally within this range here. Now, when we're looking at our pH table, you want to remember that anything going lower is acid, so that's battery acid. It's kind of like I want to drink only 0 battery acids, no battery acids. So we've got our battery acid here, and then we've got things like bleach all the way into our alkalosis. So where we range with our blood is usually in that 7.35 to 7.45. And if we go lower than 7.35, it's more acidic. If we go higher, it's more alkaline. Now here we've got our acid-base imbalances. We've got pH, which is the blood, PCO2, respiratory, HCO3, which is your bicarb, and we're thinking of metabolism, we're thinking of kidneys. So whenever you're interpreting your ABGs, always start with the pH. You always want to start with the blood. So you want that to be that 7.35 to 7.45. If it's in that normal range, then it's normal. Then you've got CO2. So what I want you to start thinking of is CO2 as an acid. So if I've got a respiratory depression and I'm holding on to a lot of CO2, then that's a lot of acid inside my body. So I'm looking at respiratory acidosis. And on here, you can see this little arrow that's showing an increase of your PCO2. Then we've got our bicarb, which with our bicarb is a base. So if I see a decrease in bicarb, I have an acid problem, an increase in bicarb, and I've got an alkaline problem. So just kind of keeping that in your head. So things to remember, always remember the normal, remember the possibilities, normal, abnormal, partially compensated, and fully compensated, and then use your arrows of normal, elevated for up, reduced for down. If all 3 are normal, ABGs are normal. If 2 are abnormal, ABGs are fully compensated when pH has returned to normal, and uncompensated when 2 values are abnormal. So that's what you're really looking for is my pH where it needs to be? If 3 are abnormal, ABGs are partially compensated or you've got a combined disorder. So looking at respiratory acidosis, if I have respiratory acidosis, before we even look at anything else, let's think about this. What is my pH going to be? It's going to be below 7.35 because I'm dealing with an acid. So if we remember CO2 as being an acid, what's going to happen to my CO2? It's going to be elevated above that 45 because I'm holding on to too much CO2. Now that we kind of understand that concept, we can kind of look and see what are the risk factors for developing respiratory acidosis. So a general tip I have is whenever you see a patient who is restless, always think hypoxia first. Because whenever we lack an airway, whenever we lack some sort of breathing, we're going to become restless because we want that air back. So looking at these, we've got respiratory depression. So if you think about a patient who has respiratory depression, that's somebody who has an opioid, or it can be somebody who has too many opioids on board. What does that patient look like? So thinking about it, it's somebody who's holding on to their CO2. So somebody who's not breathing as much because they don't have oxygen. Hypoxia, same thing, is I've got somebody who has a lack of oxygen. Pneumothorax, that is a lung collapse. So I basically have a little pocket of air located in my pleural space. I'm not expanding my alveoli. I'm not making that exchange between CO2 and oxygen. Airway obstruction, something's blocking my trachea, bronchial obstruction, which with bronchial obstruction, you can have something like your COPD exasperation, or you can have something like status asthmaticus, all these things leading into some sort of bronchial tree obstruction, where there's something causing me not to get air into the alveoli. Inadequate ventilation due to respiratory problem with inadequate excretion of CO2. Once again, all of these respiratory problems come back to this lack of CO2 excretion. So CO2 acid, that's the main goal I want you to get from this, is always think of CO2 as acid. If I'm holding on to too much CO2, it's a respiratory problem where I've got too much acid on me. Now, if we look at our manifestations, all of these make sense. We've got dizziness, palpitations, muscle twitching, convulsions. So all of these can be related to I've got some sort of issue of not getting enough oxygen. My interventions are associated with what I'm going to do to fix the etiology behind it. So maintain patent airway. That has to do with the fact that I've got an airway obstruction. Reversal agents for narcotics. I'm going to give Narcan to stop my patient from having too many opioids on board, which is causing that respiratory depression. Regulating my ventilation therapy. Bronchodilators. So if I've got this bronchial obstruction, I can give them a bronchodilator and hopefully open up that bronchus tree so that way I can get air into the alveoli. All of this is a big, long-winded way of saying I need to get oxygen into my alveoli. And then mucolytics. Now, a very fast way to look at ABGs would be to look and see that you have a low pH below 7.35 and an increase of CO2 greater than 45. So it's all about seeing that I'm holding on to too much CO2 versus my blood is going down because it's trying to compensate. So here are some of the treatment aimed at improving ventilation. So these are some of the things you can do to fix that vent problem. You need to fix the breathing problem. So what's ever causing them to not be able to fully expand their alveoli is what needs to be fixed. Always start with the least invasive before you go into a more invasive treatment. So elevating the head of bed, pursed lip breathing, basically trying to breathe from your diaphragm, being like those singers where you pull in all that air, abdominal breathing. Then if none of this works, we're going to our more advanced airway solutions, BiPAP or intubation and ventilation. So basically with these is I'm going to use some sort of machine that forces the alveoli to stay open. So I'm going to use them to have that exchange. The next one is our respiratory alkalosis. So when we think about this, CO2 is what? An acid or a base? You can pause the video and kind of answer this. Yes, CO2 is an acid. So thinking about that, if I'm losing a lot of acid and I'm breathing out a lot of CO2, what does my patient look like? Hyperventilation. Yes, they're basically breathing out as quickly as they can to expel all of that CO2, and it's causing the blood to become alkaline. So risk factors are things like hyperventilation, altitude sickness, your asthma, pneumonia, all of these different things that are going to cause my patient to breathe, hyperventilate. Now, with your asthma and pneumonia, if they get worse, then it can lead into respiratory acidosis. So this is just in the hyperventilation stage. Manifestations, tachypnea, anxiety, tetany, basically feeling like pins and needles, chest pain, all of those things that are associated with having that anxiety attack, breathing very quickly. So what are my interventions? So thinking about this, if I know that it's hyperventilation, how can I intervene to cause my patient to stop hyperventilating? Reducing anxiety, rebreathing techniques. So you can have them breathe in a brown paper bag, cup hands over the mouth to try to slow the breathing. It's all related to trying to slow how fast they breathe because I don't have enough CO2 in my system now. The next one is our metabolic acidosis. So if we remember, bicarb is an acid or a base. So yes, bicarb is a base. So if I do not have enough bicarb, I'm going into metabolic acidosis. So we've got different types of risk factors, and some of these will go into more depth in the next slide. But some of those are diarrhea with the potassium loss. Body tries to compensate, so it increases potassium. Metabolic acidosis, hyperkalemia. So that's the big thing, is hyperkalemia is one of the big risk factors for metabolic acidosis, as I've got too much potassium in my blood. Fever, hypoxia, starvation, seizures, overdosing on your aspirins, DKA, dehydration. So one of your first actions is to always watch that cardiac system, because remember, potassium equals heart. So potassium has a lot of different things that it does, but one of the main things it does is control that heart rhythm. Vital signs are going to be bradycardia, weak pulses, hypotension, tachypnea. Because if you look at these, a lot of them are associated with that hyperkalemia. So if you've got a good grasp on your electrolytes, it makes it easier when you're looking at your vital sign changes. Now with tachypnea, what is my body trying to do when it breathes out very quickly like that? It's trying to expel some of that acid in the form of CO2. Flaccid paralysis, confusion, hyporeflexia, lethargicness, warm, flushed, dry skin, Kussmaul's respirations. So all of these here can also be associated with hyperkalemia. So your interventions: treat the underlying cause, administer fluids, electrolytes, IV sodium bicarb. Then we've got metabolic acidosis. With acidosis, hyperkalemia may occur as potassium shifts out of the cell. So remember, potassium lives in the cell, and when we become that acidosis, we've got it moving out of the cell into the extracellular space. Serum potassium will go up in metabolic acidosis and down in metabolic alkalosis. As acidosis is corrected, potassium shifts back into the cells and potassium levels decrease. So that's what the real problem is we've got all of this potassium leaking out of our cells into the space, and now we've got too much potassium in our blood. So we want to monitor our potassium levels and make sure we're watching our cardiovascular system. Serum calcium levels may be low with chronic metabolic acidosis, and you want to correct before you treat your acidosis. Now we're getting into metabolic alkalosis. So once again, I'm going to ask that question: is bicarb an acid or a base? So it is a base. So if I have too much bicarb, then I'm going to go into metabolic alkalosis. So if we remember back in thinking about our hydrogen that I talked about, our three chemicals. So with this, hydrogen is a lot of times associated with your stomach acid. So if I lose a ton of my stomach acid, what's going to happen to my blood? It's going to become basic or alkaline. So things that are your risk factors: ingestion of antacids, because once again, I'm decreasing the acid in my stomach. All of these are associated with that decreased acid. GI suction. Hypokalemia. So once again, I don't have very much potassium in my blood. TPN, blood transfusions, prolonged vomiting. I'm losing stomach acid. So your manifestations are usually associated with hypokalemia. You're going to have hypertonic muscles, dizziness, all that. And then looking at this, decreased respirations. Once again, what is my body trying to do? It's trying to fix the problem. How is it trying to fix the problem? It's holding on to CO2, which is an acid, to try to fix this. You want to treat the underlying causes, administer fluids and electrolytes. So metabolic alkalosis, most commonly due to vomiting or gastric suctioning. So usually those are the main things that they'll kind of ask about. It may also be due to medications and too much IV bicarb. So that's the thing, is if we're trying to fix metabolic acidosis, we can accidentally put our patient into metabolic alkalosis. Now, the other thing is long-term diuretic use. And what type of diuretic specifically am I talking about? I'll give you a second to kind of answer that. And usually the one I'm talking about is your loop diuretics, because what happens with loop diuretics? They basically urinate out all their potassium. So since they lose potassium and there's no potassium in the blood, that are higher risk of becoming metabolic alkalosis. Hypokalemia will produce alkalosis. It's due to a low extracellular potassium concentration. Potassium shifts out of the cells, and in order to maintain electrolyte neutrality, hydrogen shifts into the cells, raising your blood pH. So that's basically what's happening within the body system. So manifestations are symptoms related to decreased calcium, respiratory depression, tachycardia, and symptoms of hypokalemia. So I hope that this was helpful, and it's a very brief kind of understanding of what's happening in our body. Thank you.